Gino, can we start? Gino?
Yes, ma'am. Yes. Ma'am, Arun sir is not yet logged. I will.
Saturday's class, usually no moderator is there, no? Anyway.
Okay, madam. Good morning, everyone. Today's topic is German rectal cancer study. That is also known as CAO, ARO, AIO 94 randomized phase 3 trial.
No. Has he told you?
Randomized phase 3 trial.
Can you hear me?
Ma'am, am I audible?
You're audible. Why don't you call him up if he has told you?
Madam?
Why don't you call him up if he has told you already?
Okay. He told to start the class. Hello? Hello? Good morning, everyone. Today's topic is the topic of discussion is the German trial, which was published in 2004. The first publication was in 2004. Then this is the main author of the study. There is Rolf Sor. He is the professor of Department of Radiation Oncology, and the question that is addressed in this trial was actually the pre-operative chemoradiotherapy versus post-operative chemoradiotherapy in locally advanced rectal cancer. Which is better? That is the question which is addressed in this trial. And coming to the study proper, I will just briefly explain what was the context in which this question was taken for the study. It was in 1980s. These landmark trials, that is gastrointestinal tumor study group trials, which published in 1985 and 1986, which by which it was almost standardized that the post-operative combination chemoradiation is the standard of care for adjuvant rectal cancer. These are the other trials which contributed into it. This is the Mayo Clinic trial and other trials like NCCTG, N79 4751 trial, and the Norwegian Adjuvant Rectal Cancer Project Group, and NSABPR01 and NSABPR02 trials. These are the main landmark trials which published in 1980s. And through these trials, by the results of these trials, the National Institute of Health consensus has actually standardized the treatment of locally advanced stage 2 and stage 3 rectal cancer as surgery with the adjuvant chemoradiation in 1990. And following 1990s, in the early 1990s and the later years, these are the other trials which came before the German trial, the Swedish trial and the Dutch trial also studied the pre-operative radiotherapy, and they studied the effectiveness of the pre-operative radiotherapy in 1997 and 2001, and they found that pre-operative radiotherapy is better and is also good, doing good as well. And so there a doubt developed actually whether the pre-operative chemo radiation, if chemotherapy also added into the pre-operative radiotherapy, whether the patients will develop a more response, or is it better than post-operative chemoradiation. So this is the situation in which in 2004 this German trial actually started. Questioning this scenario, that is whether the NIH consensus standardized in 1990 that the chemoradiation, post-op chemoradiation is the standard for the locally advanced rectal cancer, followed by which these main trials like Swedish trial and Dutch trial, which published in 1997 and 2001, where they found out that pre-operative short course RT is also good for locally advanced rectal cancer. So they considered this as a question and considered for the study. Coming to the trial, this is initially published in a New England Journal of Medicine in 2004, and that is the 5-year data, and the 10-year data, follow-up data, is published in 2012. That was in Journal of Clinical Oncology. Coming to the proper trial details, the trial actually started in 1995, around 5 years after the NIH consensus, which came in 1990, and they recruited patients till 2002, and a total 823 patients from 26 institutes were recruited. And in 2004, they published the initial data with the 46 months median follow-up, and in 2012 they published the data with 134 months of median follow-up. The inclusion criteria was only the stage 2 and stage 3, that is locally advanced rectal cancers. They avoided stage 1 and stage 4 cancers, and exclusion criteria was patients above 75 years of age, and history of patients with a history of non-melanoma skin cancers, and the history of any chemo radiation and previous chemo radiation, or if the patient is having any contraindications for chemo radiation. Coming to the baseline characteristics of the patients, all the total 823 patients were randomized. At last 799 patients only recruited, and in 405 patients in pre-operative chemoradiation and 394 in post-operative. We can see the T3 and T4 clinical category, tumor category patients were almost the same in both the groups, and nodal negativity and positivity is also almost the same. But we can see the lesions which are less than 5 centimeters from the anal canal, that is low rectal cancers, were more in pre-operative chemoradiation, that is 39% versus 30%. This is the study design. Total 823 patients were recruited, and 421 were assigned into pre-operative chemoradiation, and 402 into the post-operative chemoradiation. But 406 and 393 patients were at last selected, and the pre-operative chemoradiation patients were initially given the chemoradiation with 50.4 Gray 28 fractions, that is 180 curie Gray per fraction, into 5 times a week, along with the 5FU infusion was given. That was 120-hour continuous infusion in the first week and in the fifth week. First in the first and the last week, they were given 5FU infusions, and 6 weeks followed by the surgery was done after 6 weeks. After surgery, after 4 weeks, the adjuvant chemotherapy, 5FU infusions, 4 cycles were given. In the post-operative chemoradiation patients, initially surgery was done. After 6 weeks, the same regimen of pre-operative chemoradiation was given, except for a 540 curie gray boost to the surgical site, and 4 weeks after which the adjuvant chemotherapy was given. When we see the both arms are almost the same. And the primary endpoint was the overall survival, and these are the other secondary endpoints: disease-free survival, local and distant recurrences, post-operative complications, acute and long-term toxic events, and sphincter preservation were the secondary endpoints. Coming into the results, we can see in the pre-operative chemoradiation, the some of the patients, as taught initially, 421 and 402 patients were assigned, but some patients requested the change, and at last 405 and 384 patients were assigned in both the groups. And we can see a significant drawback over here. That is, in post-operative chemoradiation, only 206 patients completed the post-operative chemoradiation, although 393 patients were initially recruited into the post-operative chemoradiation arm. Only 206 patients were completing the post-operative chemoradiation. I will detail the reasons for that in the later slides. And one of the important reason for that was 71 patients, that is 18% of the patients, were found to have a stage 1 tumor after the surgery in the histopathological examination. So these patients were avoided. 71% patients were avoided. That is 50, among 54%, 18% was from because of this reason, and other reasons I will come in the later slides. In the post-operative treatment arm, around 145 patients, that is among total 380, above 380 patients, 145 patients did not receive the chemoradiation. The main reason was, the first and most important reason was, many patients were found to have a stage 1 and below disease, that is 75 patients. And the post-operative complications, because of post-operative complications, 16 patients were avoided, and some patients refused the adjuvant treatment, and some patients, due to institutional error, it was 28 patients were avoided from the adjuvant chemoradiation. This is the chart showing the post-operative pathological tumor stage and the type of surgery which was done for each patient. And we can see in the pre-operative arm, in the histopathological examination, 8 patients are having a complete response, and post-operative chemoradiation arm is showing no patients with a complete response, and 18 patients in the post-operative chemoradiation patients were having a stage 1 tumor in the final histopathology. And sphincter the sphincter in low anterior or sphincter saving surgery was done. The number of patients, if you see in both the arms, is almost the same, but there is a twist in this, because the number of patients who were supposed to planned for a sphincter resection, when we compare with both the arms, it was less in pre-operative chemoradiation, but finally more than what is expected was actually they were able to do in the pre-operative chemoradiation. And without distant metastasis, complete resection was done in 91 and 90 patients. With complete resection, R0 resection was done in 91 and 90 patients in the both arms. This is the thing I was mentioning. That is, the abdominal perineal resection was deemed necessary in 28% of the patients in preoperative chemoradiation arm, but among 116 patients who were deemed for abdominal perineal resection, only the sphincter saving surgery was performed in for 45 patients among them. So when compared it with the post-operative chemoradiation patients, although the total number of patients underwent sphincter saving surgery was similar, the as we saw in the first slides, that the patients with lower rectal cancers were more in the preoperative chemoradiation arm. Although it was higher, the sphincter saving surgeries were more performed in the preoperative chemoradiation arm. Coming to the toxicity profile, although the acute toxicities were almost the same, the long-term overall long-term toxic effects, in long-term toxic effects, that is gastrointestinal and the stricture at the anastomotic site and the bladder issues, the grade 3 or 4 toxicities were more common in the post-operative chemoradiation arm. Coming to the other complications, although when we see that overall percentage of complications, it is almost the same, that is 36% versus 34%. And anastomotic leak was also similar in the pre-op and post-op chemoradiation arms. And the percentage of patients with the delayed wound healing was also the same, similar, and bleeding was also similar. But the long-term toxicities almost we can see in the preoperative chemoradiation patients are doing far better. This is the comparison between when we see the results published in 2004, and that is after 5-year data and 10-year data. The follow-up in 2004 was median follow-up was 46 months, and 2012 the median follow-up was 134 months. And after 5 years, 157 deaths occurred, but after in 2000 by 2012, that is after around 10 years, 341 deaths occurred. And at the 5 years, 109 were related to rectal cancers, and among 341 patients died, 223 patients were related to the rectal cancer, and among that 206 were due to the disease progression, and 17 were due to the treatment related effects. Local recurrence, we can see 53 patients had local recurrence by 5 years, and 60 patients had 7 more patients developed local recurrence after 5 years. So late recurrence can also occur. So among the 53 patients, only 15 patients had only local recurrence. That is, local recurrence alone was seen in only 15 patients, and majority of the patients were having local recurrence along with the distant recurrence. And totally around 160 patients developed a distant recurrence, and by 2012, 183 patients developed a distant metastasis. When we see the only distant metastasis, 23 more patients developed a distant metastasis alone. And the local recurrence alone, if you see, when it is 15 and 17, that is 2 more patients developed a local recurrence, and distant recurrences along with the distal recurrences, that is 38 and 43. This is another chart I have prepared for comparing the various data from 5-year and 10-year. Preoperative chemoradiation in 2004 and 2012, and also postoperative chemoradiation 2004 and 2012. The overall survival, we can see by 2004, when they published it, it was 76% and 74%. And by 2012, it became 60%. The overall survival rates were almost similar at 5 years and also at 10 years. And the disease-free survival also, we can see the numbers are almost the same, 68, 65, and 68, 67. But the local recurrence, some little bit of difference we can see. We are able to make out that is preoperative chemoradiation at 5 years. It was 17 patients developed local recurrence, 6%, and 13% in the postoperative chemoradiation in 2004. By 2012, 5 more patients among the preoperative chemoradiations developed a local recurrence that became 22, and 2 more patients in the postoperative chemoradiation patients developed a local recurrence by 2012. So that became 22 and 38. That is 6% and almost 10%. That is almost double the local recurrence occurred in the postoperative chemoradiation arm. And distant recurrence is also the same by 10-year data. That is almost 30% in the both the arms by 2012. Almost 30% developed distant recurrence. So distant recurrence didn't change. Overall survival and disease-free survival hence didn't change. That may be a reflection of the distant recurrence. And local recurrence is the one that is showing a difference. And from this data, we can what we can understand is around 5% of the patient, around some 2 or 3% of the patients can develop late recurrences after 5 years, even after preoperative chemoradiation. This is the cumulative incidence of local recurrence. That is at 5 years preoperative chemoradiation, 5 and almost 7, and postoperative 9.7 and 10%. We can see the this is the local recurrence rates after R0 and R1, and total number of patients who underwent R0 resection in the preoperative chemoradiation is 387, and around 4.6% developed local recurrence at 5 years, and 6.7% developed at 10 years. And that when compared to the postoperative chemoradiation, 240 patients who underwent an R0 resection developed a 7.7% developed local recurrence at 5 years, and 8.3% developed a local recurrence at 10 years. And this is also a little bit different. This is a separate subgroup they have identified from the postoperative chemoradiotherapy arm in the 10-year data. That is those patients who did not underwent postoperative chemoradiation due to various reasons. That is around 145 patients that I mentioned earlier. Among these patients, the local recurrence were higher, that is 12% when compared to the other two groups. This is the survival graph showing the overall survival graph and the disease-free survival graph almost hugging each other after 5 years. And this is the overall survival graph after 2012, and the distant recurrence graph after 10 years. The two graphs are almost similar. That we can see there is no gap between the lines. In 2012, this is the line chart showing the local recurrence rate. The first one is the graph of that patients who underwent, those group of patients who did not underwent any post-operative treatment. They had around 12% of local recurrence. Post-operative chemoradiotherapy 9.4%, and pre-operative chemoradiotherapy it's around 6.8%. This is the another chart which showed the local recurrence risk among patients with the macroscopically complete resection. After complete resection, how many patients developed the complete resection? R0 resection, the hazard ratio was 1, and after R1 resection, hazard ratio became 8. This is the most important difference among this table. Coming to the discussion part, we can see there are several advantages which is already identified from this trial itself. That is potential advantages of the preoperative chemoradiotherapy over postoperative chemoradiotherapy. improved the clinical compliance, improved compliance of the patients for treatment. Most of the patients who said chemoradiation is not, they don't need chemoradiation is from the post-operative chemoradiation arm. After surgery, patients are not so compliant, and downstaging through which we can increase the R0 resection, and also permitting sphincter preservation and more effective oxygen supplementation will be there in the pre-operative chemoradiation, and reduced toxicity is also seen in the pre-operative chemoradiation. Also, one another advantage, main advantage that we can uh, appreciate by the pre-operative chemoradiation arm is the logistic advantage of introducing the TA stapler when the bulkiness of the tumor is reduced after pre-operative chemoradiation, by which we can uh, improve the R0 resection. Also, sphincter saving surgery can also be improved. Although the distance from the sphincter and uh, downstaging, if we are not considering, the some amount of bulkiness of the tumor will be reduced by chemoradiation, through which we can get more advantage of introducing the stapler for the distal transection. That we can, this already we understood, there is no statistical significant difference between the distant recurrence or any disease-free survival or overall survival. Although at 5 years, at least at 5 years, we saw some difference in the local recurrence rate. But we will see at the end how much difference was there in the local recurrence at 10 years. And coming to the importance of endorectal ultrasound that they used in this trial, they actually used endorectal ultrasound for avoiding patients with the stage 1, to rule out patients with the stage 1 patients. But around 18% of the patients who underwent initial surgery, that is post-operative chemoradiation, were found to have a stage 1 disease that that may be due to the operator dependence of this investigation. And they concluded that if we can stage the patients more effectively in the pre-operative setup, that will be very helpful in finding our patients who were stage 2 and stage 3, so that we can identify the patients who will benefit with the pre-operative chemoradiation. This is another parameter they have found out, that is median time to local recurrence. That is, this was the shortest in the no chemo post-operative chemoradiation arm. That was patients who underwent only surgery. The median time to local recurrence was 15 months, only 15 months. And post-operative chemoradiation arm, it was 18 months. And pre-operative chemoradiation arm, it was the longest, that is 30 months. So they concluded that by increasing the median time to local recurrence, they can at least delay the local recurrence in patients who are undergoing pre-operative chemoradiation. This is another recent study which is can be compared with the German trial, that is NSA-BP R03 trial, which was published in 2009. They also identified that the pre-operative chemoradiation and is showing this study actually showed a trend towards a better disease-free survival and an overall survival also in patients with pre-operative chemoradiation. Coming to the conclusion, as we already saw, there is no survival benefit in disease-free survival or overall survival with compared with the post-operative chemoradiation with the pre-operative chemoradiation. And we saw that at 10 years, the local recurrence benefit is also coming up to only around 3%. And the local recurrence alone is also rare. That is, most of the patients who are having local recurrence is also having a distant recurrence also. So because of all this, pre-operative chemo pre-operative systemic therapy should be more incorporated into the pre-operative chemoradiation arm. In this trial, they have included only the 5-fluorouracil And a coming trial, a later trial, which the same group has published, that is 04 trial, they have included the oxaliplatin also into the preoperative chemoradiation arm, by which they are finding it better local control and less number of distal recurrence in patients who are undergoing preoperative chemoradiation. Thank you.
What about the quality of surgery? How did they manage the quality of surgery?
Quality of surgery, they made sure that all the patients are undergoing total mesorectal excision. And patients who were planned for sphincter preservation surgery, that was by the surgeon's discretion. They will, the surgeons individually, they will select the patients for sphincter preservation surgery.
Can you go back 2 slides? How do you explain the reduced toxicity? Because if you look at sarcomas and all, we'll say neogen therapy, there's increased wound complications and all. So how do you explain the reduced toxicity in this?
The reduced toxicity, the wound means the long-term toxicities where when they compared with the post-operative chemoradiation, the long-term toxicity profile is a little bit difference we can see. That is the more. Otherwise, the immediate post-operative complications are almost the same. It may be due to this anastomotic stricture and bladder problems, because in the preoperative chemoradiation, we are giving the radiation to the tumor itself. But the post-operative chemoradiation, the patients are getting radiation into areas where we have operated and there is no tumor actually, and they are getting the radiation to the anastomosis. In the preoperative chemoradiation, they are getting the radiation towards the tumor only. That may be the difference, making the difference.
One official answer is, in the preoperative arm, you're giving radiation to the tissue, and then this tissue is removed out. In the post-op arm, you're giving radiation to a new tissue, and so that's why the long-term like strictures are more common. The gastroenterus and the small bowel effects are more. Any other questions, please?
Gino, this was a very focused topic on the German study alone.
Sir,
so can I ask some questions? Like Arun was asking you, how did they ensure the quality of surgery? You said there is TME was done, but anywhere in the 2 papers or any other publication by the author, have they mentioned that anything regarding the quality of TME or regarding the circumferential resection margin? Am I audible?
Sir, in the trial, in the 2004 published article, they have mentioned in a small paragraph regarding the quality of surgery, and they have mentioned that TME is done for all the patients, and also they have mentioned that the sphincter preservation was according to the surgeon's discretion. And
no, that's fine, because in some of your slides you say R1, does this R1 resection include the CRM positive patients also? Because I read through the papers, I never came to any, I didn't get any data regarding whether the R1 was including the CRM positive also, because they never mentioned.
I also didn't found it, sir. It is not mentioned in any of the tables.
No, I ask this question because subsequently we all know that CRM positivity is one of the most important predictive factors, because getting a proximal margin, distal margin, I think those issues such as, so CRM negativity is one of the most important prognostic factor. And also we know subsequently that it's not TME, it's the quality of TME. The authors have said that they did TME, but what was the quality of TME? Because subsequently the MRC study showed that the quality of TME is also an independent predictor of a local recurrence. So that is not being mentioned.
Yes, sir.
The second point is that you also mentioned that there are 18% patients who are P1.
sir, in the post-operative chemoradiation.
Yeah, they were T1. So, and similarly, you also mentioned that there are 10% patients stage 4.
Sir.
So you mean to say that about 28% or at least 25% of the patients are improperly staged and treated?
Yes, sir.
Both. So, because again, they did not use MRI, or they said they use CT and endorectal ultrasound, but I think still they missed out on 18% patients having a T1 lesion, which is a very negative thing.
Yes, sir.
So the same number of patients would have been there in the pre-op chemo RT arm also. So you would have overtreated about 20% of the patients.
Yes, sir. In the pre-op chemoradiation arm, although they have found around 25 patients with.
No, that is after downstaging.
Yes, that will be after downstaging, sir.
Yeah, but without downstaging, 18% of the patients were there in the stage 1 in the post-operative chemo primary surgery arm. So if the randomization was similar, the same number of patients would have been there in the pre-op arm also. So you would have overtreated about around 18 to 20% of the patients, and improperly treated another 10% because you are missing out stage 4 disease.
Sir, it's just a doubt, sir. There is actually in the T staging, there are quite a few numbers, almost more than 70 in each arm of unknown T stages, which they have mentioned.
Yeah, Gino, I think all these points you should have brought out, because T stage unknown, because if you read into the letters written to the author subsequent to this publication, there are so many nice comments, because it's a very, these things come into picture only when you have a focused discussion. Otherwise, it's one of the most landmark trials, no question about that. So as Abhinaya said, 25% of the patients were unknown T status. So in a randomized controlled trial where you're prospectively evaluating the patients and randomizing them based on all these factors, how can you have a T status unknown? 25%. Right. No, I just brought out the points that were there in the discussion part or in the letters to editor. So when you go into this kind of focused journal presentation or into this kind of landmark trials, it's a landmark trial. No question about that. It changed the practice all over the world, and still we go by this particular data. Whenever we want to say neoadjuvant chemotherapy, we say German data. It's a nice study, but there are small issues. Which when you want to highlight, you should be highlighting in this kind of discussions, like 25% T status unknown. Again, they mentioned the leak rate is similar, but they have never mentioned, because we all know that post-chemotherapy leak rates are more. So never mentioned whether the leak rates were with a stoma, without a stoma, clinical leak rates or or radiological leak rates. These are things that are of concern when we want to assess post-chemotherapy patients. So these things are not mentioned.
Okay, sir. Yes, sir.
And one last point again, you also mentioned in your presentation that about only 50% of the patients were able to take the post-operative chemotherapy and post-operative chemotherapy in the other arm.
Sir.
Isn't it?
Yes, sir.
Whereas it was 95 or 92, 93% in the pre-operative chemotherapy arm.
Yes, sir.
So the question is, again, somebody has asked a question, whether it's improved effect of pre-operative chemotherapy or it is an effect of improved compliance to pre-operative, because when you have more than 50% patients not receiving the intended treatment, you can't attribute the improved effect in the pre-op to the improved effect of chemotherapy. It may, the entire thing may be because of improved compliance. The effect of chemotherapy may be same in the pre-op post-op, but because more number of patients were able to actually complete it in the pre-op arm, the results may have been in favor of pre-operative chemotherapy. That's one question that has been raised in one of the discussions. It's not the improved effect, but it's the improved compliance in the pre-operative phase that translates into the better results.
Okay, sir.
Thank you.
Gino, if you look into this trial, what is the take-home message it is giving? What are the plus points of radiation? What are the negative points of radiation?
Sir, plus points of pre-operative chemoradiation are, as I mentioned, patients will be more compliant, first of all, than the post-operative chemoradiation, and more number of patients will get the all trimodality treatment, and through which after chemoradiation patients will be having more downstaging, through which it will translate into reduced local recurrence and more sphincter sparing procedures. Sir. And but the if you see the other side of the chemoradiation, we can see several side effects of chemoradiation, like in nerve injury, through which patients will develop various bladder and bowel side effects and complications, post-operative complications, and also other side effects like wound complications and anastomotic leak.
Well, are these complications, are they statistically significant in pre-operated radiated patients?
No, sir. Most of the
And why are you saying?
Sir, when we compare the pre-operative and post-operative chemoradiation, this trial actually compared the pre-op and post-op chemoradiation, and which found that on the.
We don't, you know, I'm talking about this specifically about this particular trial. What are the advantages of pre-operative RT? What are the issues with the pre-operative RT according to this trial?
Issues with the pre-operative RT where the patient, that is the various complications due to radiation itself. That is acute toxicity like diarrhea and other.
High, according to this trial, in particular subset patients, all this morbidity, post-operative morbidity is high.
Sir,
is post-operative morbidity high in radiated patients?
So they actually didn't compare the complication rates between.
They might have compared in the first paper, no, 2004 paper, not this paper, second paper.
Post-operative complication rates were almost similar in both.
Understand. See, as you know, as I understand, the advantage is that there is reduced local recurrence at the same time, the increased sphincter preservation. The disadvantage being no survival differences. But unfortunately, fortunately, the world has taken this trial in a serious manner, and everybody changed their practice to neoadjuvant chemoradiation. And that is, I don't know whether that is that should be okay or little over. This trial is little overhyped. So anywhere in the tumor, multidisciplinary tumor ward, some patient getting operated without a pre-operative radiation is considered a criminal mistake, negligence. My question is, without much advantage in survival, with a lot of flaws around, so why this trial is getting carried away and respected worldwide? Do you have any answer? You know?
This is because in worldwide it is already recognized that rectal cancer is cancer in which local recurrence is very high, and trimodality treatment is anyway needed for preventing the local recurrence. And so it is this is the thing that worldwide which agreed. And so only question is only the answer to which the question that the entire world is looking into is whether the pre-operative chemoradiation is post-operative chemoradiation. Most of the areas where the pre-operative chemoradiation, most of the trials is scoring better than post-operative chemoradiation, and there are two less trials which compared pre-operative chemoradiation versus surgery only.
But that is the point is that till that time it was always adjuvant. Got it. Chemoradiation. Whereas in Europe it was neoadjuvant short course RT.
Yes, sir.
This is the first trial, or probably the first well-conducted randomized controlled trial, which took away that advantage of post-operative to the pre-operative arm in terms of statistically significant reduction in the local recurrence rate. Yes, even though the primary endpoint of this study was overall survival, in which they couldn't show any better improvement in terms of pre-op versus post-op, This study proved that giving chemoradiotherapy pre-operatively when compared to post-operative is better in terms of statistically significant improvement in local recurrence rate as well as sphincter preservation. So that is what that is the most important significance of this trial. So the post-operative chemoradiation treatment was transformed to the pre-operative chemotherapy with advantage in terms of sphincter preservation, statistically significant improvement in local recurrence. And the only disadvantage of the when compared to pre-op was post-op, and post-op, as somebody was saying, the stricture rates were more on the post-op when compared to. That's only significant difference in terms of the effect of radiation pre-op versus post-op. In the post-op radiation arm, strictures were more when compared to pre-op. So all otherwise similar toxicity with an improved reduction in local recurrence and improvement in sphincter preservation, even though those were not the primary endpoints.
The other questions are coming because if you talk to a GI surgery, they will say, I will do a surgery for a T3 rectum and then I will give it. They will say the advantages are one, it is a primary surgery, I can avoid a stoma, because if you're doing post-chemotherapy, a stoma is almost always required. And then they can give radiation later. So how will you counter that argument?
I have one more argument. Basically, the advantage of this tumor, one of the important advantage, so-called advantage is sphincter preservation. But many times what we end up doing APRs afterwards. So in a patient who is surely likely to undergo APR, are you giving any advantage in terms of any parameter? Gino, where are you?
In pre-operative chemoradiation arm, we can reduce the bulk of the disease, and this can actually increase the logistical. We can get an advantage in which we can get more space for introducing the stapler, so that we may.
And that's the reason. I know that the sphincter preservation is more in new adjuvant, and that is a known factor and advantage. But what if a patient you are already decided to go ahead with the APR because of so many reasons? And even if you look at our patients, I don't know, we are not practicing sphincter preservation in a tumor which is as low as 5 centimeter or sometimes 6 centimeter. So it is upper rectum, middle rectum, okay. But these subset of patients, we are not giving them offer of new adjuvant sphincter preservation because they are also not demanding much. So it is very, very unlike different from a patient who is in Germany, and very difficult to convince that guy to undergo APR. So my problem is, so that may perfectly GI surgeon saying that anyway you are going to do APR, and the sphincter preservation advantage is not intended. And if you look at the survival advantage, it's not much. So what is the harm in going ahead with a local recurrence with wide margin? So the German trial again showed increased recurrence because there is a lot of stress for sphincter preservation. So when you try to preserve sphincter, you tend to have local recurrence, especially low rectal cancers. But in a scenario where you can go into have a wide margin and APR, then I don't think even if you redo the German trial in this scenario, it may fail.
The answers, official standard answer is biological effects. One, the tissue is oxygenated, better radiation effects are there. Second one, you are going to radiate the tissue and the tissue is being removed out. You're not irradiating tissue which is not a diseased per se, because after APR, small bowel may come and stuck in the bowel, stuck in the pelvis. And you're irradiating there, you're going to damage the small bowel. So you have to go by the both sides. Yes, there's a surgical advantage, yes. Surgical disadvantage, yes. But post-op, the long-term advantage, because the small bowel will get stuck to the perineum and the perineal wound at least. So keep your answers ready and for the discussion part, because when you go there, questions will keep on coming up. Why can't I do it? Why can't I do it?
No, but I think the greatest disadvantage is that your investigations alone is unlikely to correctly say T3 and T4. Many times the diseases diagnosed T3 may not be T3. And
the little bit of over treatment is there. The risk of over treatment of some patients is there, but considering that the disadvantage of under treatment, I think over treatment might be better. I think.
No, that is better, but I don't know. But with the harm created, now I think the world has started rethinking to de-escalation of therapy in various sites. And if you look into this, if you follow each patient, and it is putting across innumerable difficulties for them. In 2004, I know we were worried about more of recurrence. Now it's not. we are more into quality of life because there are other things which came up, which improve with a better quality surgery and so many other things. For example, short course radiation. So these things are actually limiting the radiation and maybe having better quality of life. If you follow a patient, especially young patient who had received radiation and chemo RT and surgery, and the other functions are almost very, very bad, the sexual function and urinary function. And it is now the world has started thinking whether we can avoid a subset of patients from those morbidities, because that's also getting important.
Those morbidities are all surgeon induced. All those are surgeon induced. This is not radiation induced.
I strongly
nerve injury. The nerve injury is not a non-complication of radiation. The nerve injuries are due to the surgeon per se. It's not due to the...
That is not like that. I strongly disagree. Everything contributes.
The only thing that the radiotherapy can have is the muscle, the pelvic floor muscle function or incontinence part maybe. LAR syndrome, maybe yes, it might contribute. The other side of short course RT also the same things happening. The biological what the tissue is getting finally is the same. The final total dose is the same, but they're getting it.
No, the best answer is to have somehow more predict those early cancers and avoid any radiation at all if possible. That's the best answer. But I don't think it is. You have not reached it.
Highly unlikely considering the anatomy of the pelvis, the true proximity of the viscera. It's highly unlikely because margins are there's a limit to beyond which a wide margin can be obtained. So I think local treatment, yes, surgery and radiation might be there. And as it is, the distant mets they're taken care of by the better chemotherapy and will take care of the distant mets and the long-term survival. But local recurrence per se, I think still surgery and radiation will play a role in, at least in rectum per se.
Okay, I'm done. Thank you.
Thank you, sir.